Hello, everybody. Let's get started. If everyone would take their seats. Okay, so welcome to the plenary on reducing the global mental health treatment gap through implementation innovations. I'm Steve Wine. I'm professor of psychiatry and director of the Center for Global Health at the University of Illinois at Chicago. And I conduct a program of research in global mental health focused especially on refugees and migrants funded by NIH. But today I'm wearing the hat of the moderator. So, we are here to tell you that global mental health is a young, late-blooming child in the global health family. But she's coming on strong, making big waves, and poised to do unimaginable good around the world. So we all know the stories. We know the tears, we know the suffering, we know victims of violence, we know people who are shamed and isolated and can't get the help that they need. The needs are enormous. I don't think that I have to convince any of you of that. But only 12 years ago, a landmark 2007 Lancet Global Mental Health publication issued a call for action. And they said, "We call for the global health community, governments, donors, multilateral agencies, and other mental health stakeholders, such as professional bodies and consumer groups, to scale up the coverage of services for mental disorders in all countries, but especially in low-income and middle-income countries. We argue that a basic, evidence-based package of services for core mental disorders should be scaled up, and that protection of the human rights of people with mental disorders and their families should be strengthened." Over the past decade, many of us have been answering that call in LMICs around the world to reduce the treatment gap for adults and children, women and men. The facts are that some 75% of persons in low and middle income countries who have serious mental health problems, mental disorders, just don't get the treatment that they need. It's not because the interventions don't exist. We have good evidence-based interventions. It's often because there aren't adequate mental health resources in those countries. So that work involves adapting those kinds of evidence-based treatments, combating stigma, building scalable models, and strengthening policy frameworks. So we're hearing a lot about implementation science at this meeting, CUGH, and you can bet that you're going to hear a lot about that at this plenary because global mental health is all about implementation and scale up. But that's not all. Last fall, we saw the publication of a new Lancet Commission on global mental health, and we have two of the authors here today, which is really fantastic. And that Lancet publication is a renewed call for action, but very significantly, it reframes the challenge of global mental health in a way that's much closer to the field of global development and to sustainable developmental goals. So today I'm really pleased to present for you three amazing leaders in global mental health and amazing women leaders in global mental health. I have personally learned a great deal from each of them, and I know that you will too. So let me briefly introduce them. I'm going to introduce all three. So Pamela Collins, right here, is professor of psychiatry and behavioral sciences and global health at the University of Washington, where she directs the University of Washington Global Mental Health Program. She's a psychiatrist and a mixed methods researcher. She has 25 years of experience in global public health and global mental health research, education, training, science policy, leadership. Prior to her current role at UWashington, She directed the Office for Research on Disparities in Global Mental Health and the Office of Rural Mental Health Research at the National Institute of Mental Health, which is where I happen to get to know her. While at NIMH, she led the development of numerous initiatives on mental health in low and middle income countries and on vulnerable populations in the US and around the world. She was commissioner for the Lancet Commission on Global Mental Health and Sustainable Development, and a leader of another landmark publication and initiative called the Grand Challenges in Global Mental Health. And she launched her academic career at Columbia University, where her research focused on social stigma and the intersections of HIV and mental health in US, Sub-Saharan Africa, and Latin America. And then we have Mary McKay. Mary McKay is an old friend and colleague from University of Illinois Chicago. Welcome back home again, Mary. We're glad to have you back in Chicago. Mary, in 2016, joined the Brown School at Washington University at St. Louis as their dean, continuing the school's legacy of creating vital knowledge, initiating social change, and preparing leaders to address social and health challenges both locally and globally. And Dean McKay brings a wealth of critical scholarship and leadership in the areas of poverty, mental health, the health prevention needs of poverty-impacted youth and families, both locally and globally. Prior to coming to Washington University, Mary was a professor of social work and the inaugural director of the McSilver Institute for Poverty Policy and Research at NYU's McSilver School of Social Work. So welcome, Mary, again. Welcome, Pamela. And then we have Florence Bangana. Dr. Florence Bangana has extensive knowledge and skills in mental health policy, planning, and programming. She has combined master's level training in psychiatry and health policy, planning, and financing. She combines this with over 20 years of mental health policy and planning work, beginning in the Ministry of Health in Uganda in 1996, where she established a mental health division, and then she joined the World Bank in 2000 as one of the first public health specialists in mental health. She worked with the World Bank and many client countries from around the world. From 2007 to 2014, she worked at the Makerere University School of Public Health as an adjunct research fellow, and she's also been a consultant to the Carter Center Mental Health Program in Liberia, on and off for many years, involved in training many mental health clinicians in Liberia, and she was involved as a principal investigator in the Grand Challenges Project, Mental Health Beyond Facilities. She was also involved in Ebola work in Sierra Leone and in northern Nigeria, and she is also a commissioner of the Lancet Commission that we mentioned before. So we really have a fabulous group of presenters today. So why are we here? We're here to show you that the revolution is happening now in global mental health, and it's being felt all over the world. We believe that the innovations in global mental health have profound implications also for mental health in high-income countries, which, truth be told, aren't that much more advanced than low-income countries, including our own city and state. Lastly, we want the global health family to take notice. Take notice, of course, that mental disorders or mental health conditions, just like HIV/AIDS, are addressable public health and clinical problems. But also take notice that the practice and research and policy innovations that global health is making right now, especially regarding such issues as implementation and stigma, have much to teach global health's larger family, our older brothers and sisters, about how to address the most demanding health challenges. So thanks again for coming. We're going to have 3 presentations, and then we'll do Q&A afterwards. Pamela.
Okay. this. This is green. All right, good morning, everyone. It's a pleasure to be here. It takes a minute to get oriented with your little clicker up here. It's a pleasure to be here, and I'm delighted to start this session by talking about the Lancet Commission on Global Mental Health and Sustainable Development. Anyone who's been involved in mental health globally, and when I say globally, I mean globally, whether here in the United States or any other country, really has to be an advocate. And I think all of us have learned in our many ways to advocate for this field, and to think about what is it that we can contribute that ultimately leads to impact. And this slide is a kind of diagram of some of the elements that Jeremy Schiffman and Stephanie Smith emphasize as key elements of bringing a global health issue to priority for decision makers, for policy makers, et cetera. So first you need actors. You need people who are motivated, a group of advocates who can come together in a coherent way to make the case for the importance of the issues that they want to represent. In our case, that's mental health. You need a policy context that's friendly to the issues. You want to take advantage of opportunities. One of the big ones most recently was the effort to ensure that mental health was integrated into the Sustainable Development Goals. That was a really successful policy window, but it took a lot of advocacy from the global mental health community. Next, you need ideas. You need ideas that you can communicate about your issue. And those ideas need to be salient to other people. People need to understand, why is mental health relevant? Why is it relevant to what we do in global health? How is it relevant to child health? How is it relevant to HIV? How is it important in and of itself? And we need to take care and understand how we communicate our ideas clearly. And finally, the characteristics of the issue need to be well articulated as well. And one needs to be able to show that the issue is serious, that there's a problem, and I'm going to be talking about that in the subsequent slides, but we also need to show that there are solutions to those problems. And we need to show that those solutions are feasible and can be implemented in a variety of contexts. So this is what we need for impact, and we'll walk through some of these elements in this presentation. As Steve mentioned, this field has been evolving for quite some time. But I think one of the more important landmarks, and you got to hear from two of the leaders of this effort yesterday, was the publication of the Global Burden of Disease 1990, which for the first time highlighted that mental disorders were leading causes of disability around the world. And this really put this area on the map. As you can see, since that time, there have been a number of key publications that have contributed to the actor power in this field. But each of those has made the case that mental disorders are serious, mental disorders can be disabling, and that they need to be carefully integrated into the other areas of global health. And a lot of that advocacy has been around ensuring that we integrate mental health care into primary care, and over the years that's broadened to integrating it into many other platforms of care, and now with the Sustainable Development Goals saying, how do we actually integrate this into global development as well? So this is just a reminder that the Sustainable Development Goals include the end to poverty, dignity, prosperity, justice, partnership, taking care of our planet, and ensuring that people have healthy lives, knowledge, and inclusion of women and children. And Goal 3 of the Sustainable Development Goals is the explicit health-related goal. But what we want to also demonstrate is that mental health is relevant to more than Goal 3, but in fact to many of the other Sustainable Development Goals. And I want to give you a sense of this, the importance and the salience of this issue. This slide is showing you the global burden of disease due to mental and substance use disorder, which is large and increasing over the last 25 years. These disorders now account for 1 in every 10 years of lost health globally. And what's striking about mental disorders compared to other non-communicable diseases is shown by these tall blue bars. You can see that the x-axis represents age, and that these are disorders that begin in youth. These are disabling disorders of youth that often emerge in adolescence, and the 75% of them emerge by the time people are 24. And these disrupt education, disrupt beginning a job, disrupt the times that people are having families. So this is important to recognize. At the same time, these are disorders that occur across the lifespan, and the red bars on the right side of this image show the increase in dementias and related disorders that also affect people. The smaller bars represent substance use disorders, which also occur across the life course, and of course are extraordinarily disabling as well. But they're not just disabling. These disorders are also deadly. I'm just going to show you that when you actually look at the cause-specific deaths that have been calculated for mental disorders, it doesn't look so big. This is 838,299 deaths directly attributed to mental disorders. This data comes from the Global Burden of Disease study. But when you actually look at the excess deaths that are associated with mental disorders, that number changes to more than 13 million. And this is largely because of comorbidities with cardiovascular disease, diabetes, HIV, infectious diseases, comorbidities with disorders that increase the mortality for people living with mental disorders. In fact, around the world, on average, people with in particular serious mental disorders have a lifespan that's decreased by up to 20 years. So this is a significant disparity that we need to be aware of. And people with severe mental disorders have 2 to 3 times higher risk of death due to cardiovascular disease, 2 to 6 times higher risk of death due to respiratory disease, 2 to 3 times more likely to die from an accidental death, 2 to 4 times are more likely to die from an infectious disease, and 2 to 4 times more likely to die from homicide or violence, as opposed to being perpetrators, more likely to be victims. The other issues that we need to consider when we think about determinants of mental health are social determinants. So violence, 1 in 3 women and girls around the world experience violence in their lifetime. 2 billion people in 35 countries and territories are affected by fragility, conflict, and violence in our world today. Nearly 37 million people live with HIV. Around 1 billion urban dwellers live in informal settlements. These are contexts that all contribute risk to developing mental disorders, and so social determinants are an important place to intervene. But there's more. There's an economic burden to mental disorders as well. An estimated 50 million years of work could be lost due to common mental disorders like anxiety and depression. And mental health conditions could cost the global economy up to $16 trillion by 2031. So these are expensive in many ways. Human rights abuses unfortunately, have been a significant part of the history of the treatment of people with mental disorders. But I want to just bring your attention to the fact that you see an image of a prison in the United States. A large number of people suffering from mental health problems are actually treated in prisons. Our prison population has an overrepresentation of people with mental disorders. The second image is an image of a mental health care facility in a low-income country where, because of the dearth of funding in the Ministry of Health, in the public system, these kinds of private facilities are where people often go when they're at their most vulnerable. So to quote my colleague, Shekhar Saxena, when it comes to mental health, all countries are developing countries. And I want to just take a minute to say a bit more about that as we worked on the Lancet Commission on Global Mental Health, we really took a global perspective. So this commission is not about low and middle income countries, it's about high income countries, it's about middle income countries, it's about low income countries, and the work that all of us in the world need to make to ensure that we can improve the lives of people living with mental disorders. So, just to summarize quickly these first slides, the reasons to invest in mental health. We need to promote human rights and reduce exclusion. We need to get people care that's not behind bars. We need to reduce human suffering. We need to prevent premature deaths. We want to reduce economic costs to society, and we want to reduce poverty and social disadvantage. So given these very good reasons, one might expect that investment is plentiful. I'm just going to show you that when you look at the years of life lived with a disability in countries from low income to high income, and you can see that this is what's represented on the y-axis here, and then look at the percentage of mental health spending in these countries, there's an incredible gap. So similarly, development assistance for mental health is pretty abysmal. So again, if you look at the dollars per DALY that are invested in HIV/AIDS, maternal and neonatal health, malaria, tuberculosis, then non-communicable diseases, and I just want to point out that what you see for non-communicable diseases is, I'm not gonna click and you're suddenly gonna see a bar. That's just nothing. It actually doesn't register on this scale. And similarly for mental and substance use disorders, the investments simply are not near on par with other investments in global health, despite the fact that these are leading causes of disability, in the case of NCDs, leading causes of mortality around the world. But we have other issues too with the quality of care. We have not been able to actually get great quality of care anywhere in the world, whether in high, middle, or low-income countries. And this is representing the minimally effective treatment rates for depression, anxiety, and substance use disorders. So this kind of aqua color is what you see in low and middle-income countries. So if someone has an anxiety disorder, about 2% of people with an anxiety disorder will get minimally effective treatment. About 4% of people with major depressive disorder will get minimally effective treatment, and only about 1% of people with a substance use disorder will get a minimally effective treatment. What does that look like in high-income countries? It's not great. We're only talking 14% of people with anxiety disorders, less than 1 in 4 people with major depressive disorder, and only 10% of people with substance use disorders actually receive minimally effective treatments. So there's a lot that has to be done. And the Commission, in looking at these data and looking at, yes, we've made progress, but yes, we still have incredible challenges, thought about how we need to reframe the way that we're thinking about global mental health. And we need to reframe in these ways. Let's bring, along with addressing the treatment gap, we need to really emphasize promotion of mental health. We need to emphasize prevention of mental and substance use disorders and universal health coverage. All of these are Sustainable Development Goal targets. All countries are developing when it comes to mental health, as I just mentioned, but we have the luxury of a global community that is collaborating with each other, that's communicating with each other, so the opportunity to learn from innovations that are happening everywhere in the world. A life course perspective is essential. We need to be thinking about the life course and where we can intervene in order to do effective prevention as well as effective treatment. And finally, go beyond addressing the treatment gap to also reducing the prevention, care, and quality gaps that will ultimately lead us to reduce the global burden of mental health problems. So the guiding principles of this reframing are 3: using a dimensional approach to diagnoses, which I'll explain, the convergent approach, which says, how do we bring together what we're learning from neuroscience, social science, clinical sciences, and social determinants all together, and how do we ensure that we are addressing human rights appropriately? So the dimensional approach says, rather than working strictly with categorical diagnoses, you either have something or you don't, let's recognize that we all fall somewhere along a continuum from mental well-being and no distress, all the way to, as you see here, we're sort of staging a stage 4 of living with persistent symptoms and often treatment-resistant or disabling symptoms. What this does is that enables people to target, okay, where do we need to focus on mental health promotion? How do we focus on prevention? And better able to target treatment for people that are at these different stages along a continuum. The convergent approach says we have biological determinants to our health. Our brain, over the course of our lifetime, has periods of plasticity, periods of pruning, and periods of senescence, and we need to recognize that these are normal activities that happen across the life course. And with those, and with social influences and social experiences or exposures, we may or may not develop symptoms of a disorder. And in fact, some of our exposures will protect us and some of them will make us more vulnerable. But keeping a life course approach, thinking about how all of these exposures converge is going to be important, again, to thinking about interventions. And just quickly to see what this looks like in a more dynamic image, genes are risk factors. They can protect or they can confer risk. And the influence of genes happens over the course of your lifespan. There are critical periods where there is more activity in the brain for pruning and differential maturation. Adolescence is one of those periods of time. And then, of course, as you grow older, this is what happens to all of us. We have senescence of our neurons. And we have to recognize that our environments influence what happens across the life course. And taking all of this into account, we can better understand the incidence of mental and substance use disorders. Finally, recognize that mental health is a fundamental human right, and that people living with mental ill health should be at the center of our planning of services and challenging of stigma. This is an important emphasis. The other issue that the commissioners identified were innovations in care. So given our challenges, given our reframing, what innovations in care can we move forward into the future? One of these is the use of psychosocial interventions delivered by non-specialist providers. This has been particularly relevant in low-resource settings. The use of digital tools for the health workforce, for the health system and the affected person, and using balanced models for the full spectrum of mental health problems. Finally, engaging community to increase the demand for care and accountability for care. And how do we do this? So I just want to draw your attention to aspects of mental health care that have actually been influential across other areas of health care. So in the field of mental health, for many years, there's been an emphasis on taking care out of hospitals and into community settings, a commitment to involving patients and family members in planning and providing services, providing aspects of social interventions alongside psychological and pharmacological treatments that are tailored to the needs of specific individuals. So this is really the hallmark of person-centered care. And doing this through multidisciplinary teams. This is something that's happening in chronic disease care, but it has been happening for quite some time in the mental health field. Non-specialized providers have been an amazing new human resource for delivering psychological interventions. And I just want to underscore that these interventions can happen in fragile places. This is a study that Judy Bass and her colleagues led in the Congo for survivors of sexual trauma, showing that using a lay health worker to deliver cognitive processing therapy was effective in reducing symptoms of depression as well as symptoms of trauma. So these are people with high school educations who can be trained with good supervision to deliver effective interventions. And I'm just going to flash through some of these. The topic of refugees came up, and I'm sure Steve will say more about this later. But again, we have an accumulation of evidence to show that these kinds of interventions can be adapted for many cultural settings, that the human resources available from non-specialists in many countries are the right folks to deliver these interventions. So this is exciting. Similarly, given that health systems are quite different from low to middle to high income, we are now thinking, there are now approaches to think about what should happen in a setting that's a low income setting. How does one ensure that primary care is the basis of service provision? How does one utilize secondary health care in these contexts? And when should tertiary health care be emphasized? This is the balanced model of care. Recognizing again that we can integrate mental health into different platforms of care, but this base of this treatment pyramid, self-care and informal community care, should really be the emphasis of what we do. The Disease Control Priorities, Volume 3, or third edition, has a wonderful chapter on mental, neurological, and substance use disorders and gives you a great overview of where the evidence base stands on these interventions around the world. So, guided by these principles, the Commission outlines a blueprint for action, and we have 7 main recommendations, which I'll go through quite quickly. One is to ensure that mental health should be reframed using the Sustainable Development Goals framework, recognizing, as I mentioned before, that yes, there is a health-related target, but the other areas of sustainable development also have both distal and proximal relevance to mental well-being and mental health. Mental health care should be an essential component of universal health coverage. That we need to use public policies like the WHO's Mental Health Action Plan to protect mental health, and this action plan will be continued into the future. We need to ensure that we listen to and engage people with lived experience of mental health problems to help shape treatment, help shape policy as well. And finally, we need to invest far, far more on mental health. There are guidelines in the Mental Health Action Plan for what countries should strive for. Many countries have not met these, but that plan will be extended to give people more opportunity. Finally, we need to use research to guide innovation and implementation. And we need to strengthen our monitoring and accountability to ensure that countries are actually making progress. So we want to reframe mental health as a global public good. It's a universal human right. It's an indivisible part of health. It's important to all people in all countries. It's especially relevant to young people and a crucial contributor to human capital. So we're moving from no health without mental health to no development without mental health. And with that, I just want to acknowledge the other members of the Commission and thank you for your attention.
Well, Pamela, I think you summarized decades of work in 21 and a half minutes. And so it's a big challenge for me to go after you, but thank you so much. So good morning, everyone. I am always a huge fan of Dr. Collins. We've worked together for a number of years, and I credit her with really being an effective advocate from the academy, from her position in government, to really do what Steve also challenged us to do, which is to put global mental health on an important agenda for all of us. So true to my charge of my previous colleagues, I'm going to advocate very strongly that the vast majority of us work in children's mental health and begin to think about what are the opportunities in those really formative years where we can help address the serious challenges that might threaten a child and their emotional well-being way before they become such a disabling condition. And so I'm going to talk some about children's mental health. So I'm in the privileged position of being able to focus on children's mental health both here in the US as well as across a number of low and middle income countries. But one of the things that cuts across my work, whether it be here in Chicago, New York City, across the US, or across the globe, is that children and their families face enormous pressures. And those stressors and strains often that begin in poverty and then cascade out to the consequences of poverty, whether that be violence exposure, exposure to health epidemics, substance abuse, or other threats, really do undermine children's mental health, their emotional wellness, and their ability of families to actually do their job, which is to rear children. And so when I think about children's mental health, I do think about their emotional well-being, but I think about the numerous threats in their multiple ecologies that really need to be addressed, or the numerous strengths that exist within children's ecologies that need to be harnessed so that kids' mental wellness can be bolstered. So I'm also charged on this panel with being very practical about how do we as academics, as scientists, really go about thinking about implementing and testing new strategies to address children's mental health challenges. And so one of the theories that myself and many of my colleagues who presented with me over the course of the last few days draw on is something called Practical, Robust Implementation and Sustainability Model. We refer to it as PRISM. And why did we endorse PRISM as a model to guide our implementation research across the U.S. and across global contexts? Primarily is the basis that we agreed with the statement that critical work from healthcare, which emphasizes that as long as efficacy and effectiveness trials are considered complete, without considering how those innovations would be used in non-research settings, the public health potential of the original investments will not be realized. So in very short summary, myself and so many colleagues, both on the stage as well as I'm sure in the audience, agree that our trials are just the beginning, and how we begin those trials will matter in terms of whether we fulfill this kind of challenge, that what we find will actually be usable by children, by families, their communities, the institutions surrounding them. So what's important about PRISM is that we've combined this multi-level implementation framework. What do I mean by multi-level? That unless you're designing a study that takes into account what's the likely impact on children, what's the role that family, the children's proximal developmental context, can play in addressing their mental health, what are the community incentives or barriers, as well as system and infrastructure barriers, and thanks to Pamela, in a new set of projects that we're embarking on the African continent, she and other colleagues at NIH insisted that we do the unnatural thing of involving government officials and policymakers at the beginning of our studies, so that those with resources who can set the agenda and the priorities really can make a difference. And so PRISM allows us to think hard about children's mental health outcomes, but in multiple contexts that are going to be important either for immediately addressing their needs or for sustaining any type of children's mental health innovation that we actually develop. How do we develop those interventions? Many of you in this room know that if we've worked in global health, we've also relied on community-based participatory methods, that we've relied on strong collaborative methods to come up with new solutions. It's those same collaborative methods that we brought to our global children's mental health work. And we think about that in two ways. Collaboration as being completely critical to designing interventions and mental health supports for children that are likely to line up with those multiple levels. But also we think about collaboration as building capacity. So if mental health is an emerging field, children's mental health is starting quite a bit back from even adult mental health. And so to build knowledge about what does it mean for a child to have emotional wellness and mental health, what are some of the practices and processes that happen within families and communities that actually protect a child's mental health, and what are those that put a child at risk for emerging mental health disorders. And so we think about at every stage of a collaboration with young people, with their caregivers, with advocates, with providers, organizational and system leaders, policymakers, as both a collaborative effort, but also a capacity building effort that we're trying to knit together groups of people that truly care about children's mental health and have spheres of influence that will make a difference. So we've been fortunate to really develop a number of evidence-based practices, this being one in the children's mental health arena, although I'm actually going to get to one, Pamela, that goes back to our HIV prevention and care days, because there were mental health components in those interventions that were also on this registry, the National Registry of Evidence-Based Practice. This particular practice was designed in the US, and it's referred to as the 4 R's and 2 S's for strengthening families. Now, Steve, I still have a little bit of a Chicago accent, and so sometimes I finish this talk and somebody raises their hand and they say, tell me about those 4 hours. No, R, like the letter R. And what are the 4 R's of family life? Those are family processes that all of you, when you go home to your children, you will engage in that will protect children's mental health. They are the rules, the organizational structure that you create within your family that guides children's behavioral success. They are the relationships that you create with your children. The foundation for children's emotional relationship are the positive relationships that they develop within their families. They are roles and responsibilities of each member of the family, from parents taking their leadership role within families, to children building competence and success. And respectful communication is the last R, named by a grandmother, because those of you that have any contact with grandmothers know they don't play around and insist on respectful communication, not just talking and listening to each other. The 2 S's are stress and social support. Those are a set of social support, key kind of building blocks for how your family functions even better than it can by itself. Without social support, really the opposite, isolation. Families often struggle to do the basics of what they're charged to do, which is to rear their family. And stress completely undermines a parent's ability to actually be in a leadership role. So those 4 R's and 2 S's come out of an evidence base that suggests that families both in the US engage in a set of processes that protect their children's mental health, and if those processes are weak, sometimes challenges can emerge. But it's not necessarily the family's only responsibility. Those protective processes have to come from communities that support parents and families. They have to come from institutions like schools and healthcare facilities that make that job easier. So this evidence-based practice was developed here in the US, where it brought together children and their caregivers in a form of a multiple family group to really be on a journey to assess what works well within a family and where additional supports were needed. When we received a call first from our state, New York State, and then now on the continent across Africa, we were charged with not doing a small trial, but doing what one of my workers is doing, which is he's jumping off a 30-foot pole in one of those adventure reserves to go big or go home. Go to scale across a whole state system. Go to scale across New York City. If you have something that might help children, go to scale across thousands of children in a low and middle income country. And so that's been the set of projects that over the last set of years my colleagues and I have been embarking on, is to be bigger and to study more children and to work with more partners than we actually ever thought possible. And I can tell you at least he lands safely on the ground. May the same thing happen to my research group as well. So I'm going to end with just talking a little bit about the work that we're doing across Africa. Several years ago, we had the opportunity, thanks to the support of the National Institute of Mental Health, to really take what we knew and what we had learned from a set of effectiveness trials in the US, and in strong partnership with investigators in country, and to be exact, 4 countries on the continent, really try to figure out what of that science would be useful in the countries of Uganda, Kenya, Ghana, and South Africa. And so to really think hard about, would it be possible not to do a small adaptation trial, but a very large trial to test whether, if our collaborative group adapted and aligned the needs of young people in Uganda, the needs of their families, the strengths and capacities and needs of their communities, the infrastructure with both its serious strengths and challenges, could we actually go to scale with an EBP and actually test that? And so that is the work that we and my partners, Dr. Fred, who you heard if you came to our workshop earlier in the week, Dr. Ozge, and others have embarked on. Why the country of Uganda? I know that my colleague will talk a little bit about the work on the continent as well. One of the things that many, many countries on the continent are experiencing is what my colleague calls the youth bulge. There are sheer large numbers of children. These are very young countries. In Uganda alone, 56% of the total population are made up of children. So if we do what Pamela's chart suggests and not intervene around their mental wellness in their childhood and adolescence, we're likely to proportionally have huge, huge burdens within countries as these children grow up. Kids in Uganda live in many circumstances. Many children live in disadvantaged communities with high rates of poverty, violence exposure, and also high rates of not only challenges to and threats to their own wellness, but to their caregivers as well as numerous health threats. It's a recipe potentially for disaster given the sheer number of children, but also the threats. And so our work in Uganda has us really try to bring together key stakeholders to try to figure out what of the evidence really applies to the context and how to put voice, Ugandan voice, into these interventions so that they might be scaled, tested, and potentially integrated into a government that is interested in mental health. So Pamela, I have to admit that as an advocate, I've had to actually use rigorous scientific methods. I've had to, in collaboration with my colleagues, create randomized trial that has thousands of children in it, and really use the best available measures, some of which quite imperfect in this area. But I've had to engage in other sets of activities as well that none of my PhD training actually prepared me for, and I'm not even sure many of our current PhD training prepares us for. Around networking and information sharing, around providing technical support in collaboration with many others around the globe, around always thinking about rigorous science simultaneously with building capacity so that I am not in the lead but in the supportive role. And we have had an amazing response from our colleagues in Uganda, in Kenya, in Ghana, stepping forward to study, to engage in children's mental health research when the stigma associated still with mental health service research is not only great for kids and their families, but also scientists and providers that engage in this work. So the last thing I want to say to this particular audience is children's mental health, global children's mental health, might be somewhat unfamiliar to you, but we have engaged in working on behalf of children and their families for decades in this space. And so part of our earlier work, which is how I know Pamela, is that we engaged in a whole set of global projects that still sustain to some extent in some of the country contexts around the world around HIV prevention and care for children. This is a project called CHAMP, also on that National Registry of Evidence-Based Practice. It stands for Collaborative HIV Prevention and Adolescent Mental Health Project. And what I learned from my HIV prevention days and care days with children and families is if you wanted those kids to take their medication, if you wanted to prevent behavioral risk-taking to keep those kids negative, you had to take into account mental health. And so many of you, although not considering yourself global children's mental health researchers, I would suggest actually are, and have interventions. This is the Amakawa family. My Zulu is not so good, but a few words actually remain. This is a set of evidence-based cartoon storyboards that we use to convey HIV prevention and now care information. Those same storyboards are in other parts of our work across the continent, now tackling children's mental health issues. One of the important things about the HIV prevention and care work is that it was exclusively delivered by community health workers, by parent peers. And so these kind of formats can be also adapted pretty straightforwardly into global children's mental health. You get the idea. I'm opening the door for many of you to use what you already know and apply it to a new area. The last thing I will say is this is one of my colleague, Dr. Fred Samala, who's at who's at the Brown School at Washington University in St. Louis. This is one of his parent meetings, an introductory meeting of parents all across a community that wanted to learn more about opportunities to strengthen their children's mental health. Why was that? Because kids' mental health is related to your functioning in school, your ability to go on to secondary school, your ability to actually financially support yourself. And those parents knew that if children were functioning well, they wanted to keep them functioning well. And those parents, many of them came with concerns that their kids were struggling behaviorally and were hoping to do something about that. Sometimes when I organize a parent meeting, a few people come, a dozen people come. People walked for miles to be sure that their kids were going to be emotionally well so that they could have the best chances. And so thank you so much. I really do also have to apologize to my panelists and to the audience. There's a flight to DC that has my name on it. And so I'll need to leave a little bit early, but I thank you for your attention. Thank you.
So we're going to have Q&A at the end, but because Mary's not going to stay for all of that, let's take a few questions for Mary from the audience, if you want. While you're step up to a microphone if you have a question, and then the others will do afterwards. But I'm going to ask a question while people are stepping up to the microphone. Mary, I know that you do a lot of work with policymakers. What do you do with them, and why do you do it? The mic's on.
I think this is on now. Beautiful, thanks. So the question, what's our collaboration and the relationships look like with government official and policymakers? Sometimes in presentation, I give NIH the credit for why we are so deeply engaged, and that was important to push our group to involve government officials, ministry, both local ministry heads, but also at the highest level of ministries involved in our project. And it was really that push that I think we needed to get us to the place where all of those capacity building collaborative workshops that we do to adapt the intervention include local officials from the Ministry of Health, Ministry of Education. And we think about that in two ways. That this is a set of programs, projects, supports for children that need to be owned deeply by the countries themselves, by the leaders themselves. And we can't assume that our elected officials have any deeper mental health information, knowledge, or understanding of what our best practices. They need to get that information from somewhere. And so we think about the adaptation, the deep work around project development as capacity building for our policy colleagues as well. I will say that once you are in relationship with kind of policy officials and government officials at multiple levels, you build those trusting relationships the same ways you build with communities and families. They actually have some needs that you can help with as an academic. And so one of the things that my colleague, Dr. Fred, was able to do was able to provide what we hope will be some language into the final mental health bill that is under consideration in the country of Uganda. That was incredibly important and came out of familiarity and contact with those government officials.
Thank you, Mary. Two questions. Make them brief, and then Mary will respond to both. You first, please.
Hi, my name is Jacqueline Buzalis. I'm a medical student from UT Health San Antonio. First of all, thank you for your work. I was wondering how you chose your sites in Uganda, the area that you were working in, and if you would consider expansion to the north where there's large amounts of PTSD amongst the Acholi people.
That's other question.
I'm a student in Ann Arbor, Michigan. I'm Susan Dowling. My question is how to better invoke mental health programs into primary schools and high schools, because there's a lot of more stigma with administrations at that early age to try and hide the fact of all the mental health going on through the young people.
Beautiful. So I'm really happy to answer questions from 2 students that, Pamela, maybe we did our job and are really working on the next generation. So, so we are in the Masaka and Rakai region of Uganda. Why that particular region? Because rates of HIV, when my colleagues started on this journey, exceeded, sometimes would approach 40% of the population. So not only is extreme poverty threaten the lives of children and their families, but also disease burden. But there is certainly an interest and openness in what we learn in this pretty sizable region. Our study is set in 30 schools in that region. The final sample will be about 3,000 young people and their family members. There is clear interest in trying to figure out how you scale up country across a country, and hopefully that is where our policy officials and our ministers will help us. The second question related to schools and stigma. So our project happens to be set in schools, so I feel particularly capable of saying to you, we have to be scanning the child-serving institutions that exist in communities, whether it be in the US or across the globe, that are likely to exist and endure. And so I think it's important that we think about schools as the site for bolstering children's mental health, that we think about primary care clinics, and that we think about churches, because those are the set of institutions that likely endure from year to year. Having said that, those leaders of those institutions are likely to hold the same kind of concerns about what is mental health, how do those problems emerge, the stigma that gets heaped on children and families that struggle also helps to keep programs like ours at bay. And so that is really a capacity building and a collaborative kind of challenge that you must tackle. The one thing that Pamela knows, because she does so much collaborative work, and I'm sure you're going to say this as well, the investment in time, relationship, and the enduring kind of set of collaborations that one needs to have to get past stigma and those challenges is great. And so my colleague, Dr. Fred, has been in this region for 15 plus years. The country context that we chose, my first trip to South Africa was in 1999. I never left. And part of that has to do with what is really needed to address the significant challenges to do productive work together. So I thank you.
Thanks very much, Mary. Thanks for those questions. Last but not least, Florence. So we'll hear from Florence, and then we'll have a little more time for Q&A.
Okay. So thank you very much. I feel very honored to be here among 2 very eminent panelists. My presentation is going to be a little bit here and there because I'm presenting some examples from implementing mental health in the real life situation and not necessarily using the research approach. One thing about doing mental health policy development work is that it's very invisible. It's very invisible work. And I hope by the end of this presentation, maybe I will have stimulated some of you to get into the field of global mental health implementation science, because I feel like there's a very big gap there. So, global mental health, we have already had their opportunities. Mental health is included in the SDGs. We have had increased funding for mental health research. I'm going to move at a supersonic speed. I was given 20 minutes, and I have 30 slides. So there's been increased funding for mental health research, and some of it, big thank you to Grand Challenges Canada, is led by low and middle income countries. I believe NIMH also began to do that. So we've been having more and more low and middle income country investigators leading the research in mental health. And of course, the most recent piece is also the Lancet Commission. But before that, we also had a Nature article on mental health. So there are challenges, of course. And one of them is a publication with the title, Mental Health is in the SDGs, What Next and Who Pays? So we have managed to get it into the SDGs, but we're not very clear what happens next. Or we believe we are, because that's what is in the Lancet Commission, but it's not very clear who's going to pay. I would recommend that people read this publication. If there were increased funding to countries, what is the capacity to implement? So we know that some countries have actually had increased funding. The UK government, DFID, put a lot of money into Ghana. A lot of money, maybe 3 million or 5 million UK pounds. And that was put into a mental health authority. And on doing a review, we are not so sure that that may have been the best approach. So sometimes we say we want the money, but are we really sure that we have the capacity within countries? And some of the examples I present will demonstrate that. Then there's the whole issue of mental health and health systems. Mental health has tended, the mental health fraternity has tended to work a little bit off on the side, not mainstreaming into the general health system. And this seems, I know it does work against getting mental health actually integrated and developing mental health programs. There's also this emphasis on evidence and having to replicate evidence. So if we have evidence that maybe was developed in the North, and then replicating that evidence in low-income countries, low-middle-income countries, and I don't know if really this is the very best way, considering the different human resources, the different contexts we work in, and some of this as well I will demonstrate. So we may need to question whether evidence alone is the one that should determine what is implemented. So I will start off with a small diversion to Afghanistan. My presentation is going to be mainly on Africa, which is where I have worked most. So in about 2003, I went to Afghanistan. I was working with the World Bank at that time. And we had potentially $500,000 US, which was to be invested in mental health. So I had gone as part of a feasibility mission. So when I got there, mental health had been included as a priority in the Ministry of Health documents, but it was named as a second-tier priority. So at that point in time, they did not feel that they should be investing in mental health. It was to come in later. There was no mental health desk in the Ministry of Health, neither was there a person in the Ministry of Health responsible for mental health, and there was no mental health strategic plan. So any mental health service was actually being run out of a psychiatric hospital, and the psychiatric hospital, the main patients there were actually drug use disorders patients who were being chained to their beds so they could dry out, and that's the approach that was being used. So after looking at the situation in Afghanistan, I decided we could not invest the $500,000 US there because there was really no infrastructure for that money to be used. So that's when I met Peter Ventevogo. Some of you may know him. He's now with UNHCR. He was based in Kandahar at that time working with HealthNet. It was not yet HealthNet TPO. He was a very young, very enthusiastic clinical psychologist who came all the way from Kandahar to Kabul in order to meet with me. I had not met him before, but he made the journey, and it wasn't easy for him, but he did. And he said, so why aren't you putting the money into mental health? And I said, well, because there really isn't the infrastructure, the governance structure for this money to go into mental health. We would prefer it goes into the government, and the government is not quite ready for it. So I left Afghanistan, and I'm glad to report that I never went back, but Peter actually took it on himself to make sure that the Ministry of Health put somebody in the Ministry of Health responsible for mental health, which has now become actually a unit. A national mental health strategy was developed in 2009, they launched it. Mental health became a first-tier priority in about 2005, and they recommitted to mental health in about 2009 when this strategy came out. I was also glad to find on the World Bank's webpage that document, Mental Health in Afghanistan, prepared by the World Bank. So the National Mental Health Strategy was prepared with the support of WHO working together with the Ministry of Health. And now I believe the World Bank is much more ready maybe to make an investment with the government of Afghanistan in mental health. And this is often how it works. A seed may be planted, but it takes a long while before you see the actual results of that leading to actual interventions. I'm not sure what's going on now, but that's what I had for now. If I'm to move on to something else, is that of finding one indicator for mental health, just like we can say maternal mortality rate, or we can say under 5 mortality rate, and we get a sense of what the health services of that country may be like. We have been trying to get one for mental health. One area I will touch on is that of total mental health beds as an indicator. We know that in most of the developing world, as Pamela demonstrated, and also in some of the high-income countries, the institutions that we have, the beds that we have, may not be the best place for patients. So if we're going to use beds as the indicator, it also poses its own kind of challenges. That one is 2 photos of a state psychiatric hospital. I will not name the country because I did not come here to name and shame. But these were taken in 2008. That there is one of the patients in this institution, and you can see the state of the ward. And they were advocating for funding for this hospital. And of course, I said, I don't think we can find such an institution. So if the government itself is not willing to put in the money to do the minimum that it could do to make services more humane, it's very difficult then to invest in beds for patients when we are not able to manage the institutions. This institution did not have a clinical psychologist, it did not have a psychiatrist. It was managed by psychiatric nurses, and that was the insistence of the state to say that this is how we want it. We don't want any specialists there. So we will have to rethink what kind of indicator we use, because if we had put the money into those beds in order to achieve that measure of having done something, I think we would have done a disservice to the people with mental disorders. So moving on, we also have the issue of country-level poverty health expenditures and allocations to mental health. And we have that example there of 3 countries where I've worked most: Uganda, Sierra Leone, and Nigeria. The GDP per capita is the one I point out there, where Nigeria is actually a middle-income country. But when we look at total expenditure of health, Nigeria actually invests the least amount in health per se. And of that, in red at the bottom, you can see 3.3% of that 3.7% is what is allocated to mental health. And of that 3.3%, 91% is going to tertiary hospitals. So you find that even in countries that could be relatively well off, even in terms of human resources, the investments that are made towards mental health sometimes are the challenge. So Uganda was actually one country that was able to do so much more, and I will give that example, using limited resources, because it's not one of those, it's still a low-income country. So mental health financing in Nigeria. Nigeria is a middle-income country. Up to 70% of the population live below the poverty line in the Northeast, in the states that are affected by the insurgency. It has a pretty high GDP. On average, for the whole country, I had stated that already, 53.5% live below the poverty line. They have a fairly low maternal mortality ratio nationally, but for the Northeast, the rate is very high, one of the highest in the world at 1,500 per 100,000 live births. So expenditure on health is low, about 4.2% of GDP. The numbers are going to differ because of the sources I used. And this is below the AU target that was agreed of 15% of GDP. I had talked already about the 3.3%, most of it going to tertiary hospitals. Nigeria has a national health insurance scheme as well as private health insurance. Of this, only 5% of the population actually have access to care. And yet all health care is actually on cost recovery basis, all health care, including mental health. So the cost of mental health admission is about 45,000 naira per month in the Federal Neuropsychiatric Hospital, which is where most of the services are provided. This is about $125 per month. This doesn't include the consultant cost, doesn't include the medications. So this is usually way above what the normal Nigerian would be able to afford. Nigeria includes mental health in the National Health Sector Strategic Development Plan. It includes it in their national guidelines for primary health care, where mental health is included all the way up to the lowest level of care. And in the 3 states where I was working, they have state health sector strategic development plans that prioritize mental health. And there's also a national policy for mental health. But unfortunately, there is no mental health in the HMIS system of Nigeria. It has never been there. So they are not able to track any kind of number on mental disorders seen. There's no mental health desk in the state ministries of health, and it is only recently, late last year, that a desk officer for mental health was put in place in the Ministry of Health. There are no mental health services at the secondary level, so all the general hospitals don't have any kind of mental health service, neither is there mental health care at the primary care level, and no community mental health service. So this just demonstrates how a country can put on paper what they really think is best to have on paper, but to translate that into actual implementation can be very difficult. So what has been done? We developed strategic plans for the 3 states affected by the conflict. We developed an implementation plan for Borno. There's also a 3-state outline that brings together the 3 states, so some things are going to be done at that level. There has been some resistance to review of the national health policy and development of a national mental health strategic plan. Mental health desk officer has been appointed in Borno, and there's a plan for training of mental health nurses to be deployed to the district hospitals. Mental health is to be developed, to be integrated into the HMIS. The indicators are to be developed, and there's also a plan to train healthcare workers in MHGAP. So that summarizes what is being planned now in order to ensure that we have mental health services from the community going all the way up the system. I will probably not be able to go through this one. This is the Uganda case example. In about 1999, when the health policy was being developed, mental health was identified as one of the priorities there, and it was included in the health sector strategic plans and has been since then. This is how the mental health services are organized. We do have psychosocial services, and we also have traditional healing services, but I will not go into that. So it was in 1996, a focal point for mental health was put in the Ministry of Health, and that was myself. And mental health was included in the first health policy. We got a budget line, and because we got the budget line, we were able to get mental health funding from the African Development Bank. I believe Professor Maswa is here, and he was the Director General at that time and very supportive to mental health. So because of that funding, Uganda actually reached 4%. Mental health was 4% of the health budget. These are some of the things that were done, which I will not go into, but I just want to look at this one slide, which shows what happened after 5 years of the African Development Bank funding. You can see that capacity for provision of mental health services went up to 55% at Health Center 3. So Health Center 3 is one of the lower level healthcare centers. Other centers are a bit higher. We also have drugs were also available. Health Center 3 does not have a designated mental health worker. These are all general health care workers providing mental health services. And we thought that this was something really good because we are moving from zero and there's no designated mental health worker. The weakest link was the community mental health services, which were low. So, 2 minutes, okay. We started from about 3 disorders in HMIS. We increased them to 6, but right now we have over 24 items in HMIS in Uganda, all of them looking at mental health. So this is the framework we used. I'm not going to go into the details, but we need to look at the program components. What are they? Look at financing. What are the different levels of financing? And then the different modalities of financing, and then looking also at the levels of care from community, primary, secondary, and tertiary. So as I conclude, the questions and challenges are, is it feasible to always replicate available evidence, or can implementation science be applied to ongoing programs, especially in low and middle income countries, in order for the evidence to then be established? Then also the importance of health policy, process, and power in integrating mental health into health systems. So it's not very easy, but as was said earlier, it's really good to work with the Ministry of Health when developing any kind of program, not just mental health. There's a need to have more implementation science that studies ongoing mental health programs as they evolve, and there's a need to have cross-fertilization of mental health with health systems and global health researchers. I wasn't able to talk at all about, on the left is Mental Health Beyond Facilities, a Grand Challenges funded program where we integrated mental health into primary care as well as at the community level. And we had a smartphone. So there it was a supervision visit that also included me looking at their data and comparing it to what we had been able to collect through the mHealth program. On the right-hand side is during Ebola in Liberia, community healing dialogue, something else, an approach to community mental health that has been now scaled up across the whole country of Liberia and then replicated in Sierra Leone and the Guinea. Thank you very much.
Maybe, yes. Thank you very much, Florence, Pamela, Mary. Who's got some questions or comments they'd like to share with our great panelists? Oh, go ahead.
Curious, you know, you're working in non-Western countries, and it seems as though we may be using Western models for care. So I'm somewhat interested to understand the integration of mental health through different cultures and the appreciation for that thought processes are developed differently, and orientation towards interacting with people can be different, so how that's taken into consideration as these programs are developed.
Okay, so I'll start and Pamela will come in. I think it's really important when we replicate programs from the West into low-income countries to take into account the context. So very often, when we go into countries, the first thing is to do like formative study, which is what we did with the Mental Health Beyond Facilities project, to get an understanding of all the stakeholders, including the potential consumers of the service, but also the policymakers and what they would like to see. But I think at the end of the day, it is about providing a service in a system of care. And the WHO pillars still hold. Whether you're in a high-income country or you're in a low-income country, we still work around those same pillars: governance and leadership and human resources and the mental health services, information. So we work around the same pillars: access to medications and supplies, and yeah, so.
Yeah, that's a great question. And I want to just follow up what Florence is saying, and also just recognizing that culture influences the way many symptoms may be expressed. But for many of the disorders that people are addressing, particularly the ones that are being treated in the hospital settings, there are core treatments that are available that are kind of the same because they're human processes, right? That are the same. I think the way people understand them and the way that one has to think about the best ways of meaningfully enabling people to engage in care, I think those things differ, and one has to be cognizant of how best to do that in a given cultural setting. But I do think it's important to remember that at the core, people are people. And often the central issues can be quite similar across cultural contexts.
I'll just come in on that with a statement. There was a great debate at Columbia University in the fall between Vikram Patel, who is, I think, the lead author of the Global Health Commission, and Lawrence Kurmeyer, a great psychiatrist and anthropologist from McGill University, arguing about are we just replicating Western models in low-income countries, or are we, and all that stuff. And what I think I think really a consensus emerged from that we need to have tremendous cultural appreciation. And I think you see that when Mary described the 3 months of adaptation with all those stakeholders, and that's behind all of these projects. So I think that there is both a deep understanding of need for things to be culturally tailored, but also not to be stopped by that in addressing really basic human and public health needs with core packages of interventions that are effective all over the world. Okay, let's take this comment and this comment together. Go ahead.
Hi, thank you very much for your talk. I wanted to hear your thoughts on mental health in the LGBTQ population. As we know, this is a population with a very high burden of mental illness, including substance abuse, suicide, and also considering the fact with a lot of stigma, lack of rights, or legal issues across multiple countries that may prevent them from accessing these services. So I was wondering if there were any initiatives or strategies to address these issues in this population.
Okay, thank you. And let's take this one.
Yeah, hi, good afternoon. Sarah Sullivan, Touro University, California. And I had to step out for a minute, so excuse me if I missed some of the conversation. But I was curious to know globally if there's any movement towards ketamine for a therapy for severe depression, refractory depression. I know that just recently here in the United States, the nasal version of ketamine was just FDA approved, and a cost-effective, successful treatment for severe depression. I just wonder if the Commission knows anything about that moving in a global category. Thank you.
Let's take one more and then we'll answer all of them. Please, go ahead.
I am the person whom Florence was referring to as being supportive in the development of the program in Uganda. It has provoked me to inform the meeting that it's really Florence who was responsible for ensuring that I was supportive. I chaired most of the meetings developing the policy, but in those meetings, Florence's hand was always up, making a point, you have forgotten this, you have forgotten. And the program in Uganda now, she hasn't had much time to explain what it is. It's really beautiful. The mental health services are well structured all the way down to the communities. Of course, the quality of implementation fluctuates, but my message is that we need champions. And in each and every context, perhaps a group like this or somewhere else should have a community. I'm a surgeon. We have a very strong surgeons community in Eastern Africa. I would like to see a similar community in mental health across Africa who makes sure that there are more Florences in each and every country. Thank you.
So in response to the LGBT question, you're absolutely right. I think one of the big challenges is around policies that actually criminalize behavior that keep people from overtly seeking care, and from often in the provider community, there's a lot of stigmatizing behavior as well. And so advocacy is going to be important. And I think this is one of the areas where it's probably really, this is something where the global health community can help. So there's a lot of advocacy in the HIV community in terms of getting people access to care, getting specialized care for people, for key populations. And I feel like there needs to be a conversation in that community, which increasingly there is, a conversation about how do we actually ensure that that the holistic needs of people seeking care for whatever their medical problems may be are being met. But I think this is where you really need to find those allies in different parts of global health so that you have a voice that's stronger than mental health alone, but also where people, I think, have a track record of doing the kinds of advocacy needed at the country level.
And what about ketamine?
Okay, so regarding the LGBT issue in Uganda, I do know that they are organized. They organize themselves, and especially in relation to HIV and AIDS, there are programs that specifically target the LGBT community. But I do know that some of them have also organized themselves, especially in relation to GBV. And they have retreats, and they have access to people whom they trust, who are then able to provide them with the support that they may require. So they do have access to care. They do. At least in Uganda, I know that they do. Yeah, so there are some, anybody who knows and has listened to the news will know that Uganda may not be so friendly on the surface of it, but in actuality, in the country, they do have some freedoms. They do have quite a few freedoms, and they do go about their business as they would like, and they do meet and organize and do their thing, and so they do have access to care. Definitely, there's a lot of stigma, especially with the more, I don't know, Christianity sort of, you know. So that's kind of a bit of a problem, but I think they do have access to care. Regarding the movement in relation to severe depression, I'm sorry, I'm not very familiar with it, but definitely we have interventions that target severe depression per se. But the latest innovations, myself, I'm not aware, and maybe Pamela knows.
So for people who may not know, there's been really very striking research around the use of ketamine nasally for severe depression, and the response time is pretty immediate, so that people who have been disabled by depression with this medication can actually have that turned around within within hours. So I think the community is still trying to understand how best that can be used in treatment, and certainly in the US it's now going to be available. That's not available globally, and I think in many of the lowest resource settings, what people have really been trying to emphasize is the use of interventions that can be delivered with local resources. And psychosocial interventions have been powerfully effective, and they are easily, I think, transportable across cultural contexts because you have them being delivered by people in that context. You have people really bringing the cultural meanings that are necessary into those treatments. So I guess the short answer is that I doubt that ketamine is going to be available in many settings soon. And I think that there's still a lot of questions about how one actually uses that, what are the implications of it, and how long does it last. So I think there are a lot of health system related questions that have to be answered.
I'll give a quick response to that. I see problems in low-income countries of over-medicalization of suffering. People who will come to, say, a primary care clinic and they have a treatable depression, but they might be diagnosed with schizophrenia and given way high levels and inappropriate amount of medication. They just skipped over available, say, medicines like amitriptyline, but more importantly, psychotherapy. Pamela has been an advocate for interpersonal psychotherapy, which is a very strong evidence-based psychotherapy, has just as strong of an impact as does antidepressant medications, including in low-income countries, including with comorbid HIV and things like that. So, question?
Me? Okay. I'm Elsie Chigulimarade from Uganda, and Florence briefly talked about traditional healers, and we know that in Africa, most of the times people with mental health issues go to the traditional healers first. So I'm wondering what is being done to ensure that they are brought on board, and many times these patients don't even get to see a health care worker. So my question is, what is being done to make sure that they are brought on board to ensure that patients are properly managed?
Okay, so in Uganda, in Imbara, at Imbara University of Science and Technology, they've actually done some work where they partner with traditional healers and do some training with them and encourage them to do referral. So if a patient is deemed to be severely ill and requiring medication, they encourage the traditional healer to make referral to the hospital. And then the hospital too will assess the client, and some clients have very deeply held beliefs around their mental disorder, believing that maybe it has to do with some traditional healing, something. And so for some of those patients, they're encouraged to seek care if they feel they need to, but they have to try and continue with the care that they are already receiving within the hospital. Many countries have actually, I think Zimbabwe is one, where they have both traditional healers as well as our Western health services working together. The traditional healer is integrated within the healthcare system. So many countries are moving towards that. It's about making sure that when they do it, they are sure that they are going to be able to do cross referrals both ways and not just one way, but also that the traditional healer will not encourage patients not to take the medication. They should encourage, if they are taking medication or having to come in regularly for any psychological therapies, they encourage the patient to continue with our treatment even while they do the other consultation.
And I'll just add to that recently in Nigeria, Oyegareje led a study that was essentially trying to study this process of a collaborative care method of involving primary care doctors and nurses from the public health system to work with traditional or alternative healers. And hopefully those results will be coming out soon. But I think, as Florence says, many people are trying to learn from that and now trying to study those processes to see how they can be done even better.
Any last question or comment? Okay.
Hi, I'm Melissa Scher from St. Ambrose University. I really appreciate the overview from the Lancet perspective, and then the research perspective, and then the policy perspective. Two questions really. What do you guys think are some of the key levers to increase coordination between those? And the second question is, how can we have more of the voice of the person with the lived experience in the policy mechanism, in the research mechanism, and then, resulting in action? I'd love to hear your thoughts on those two questions.
I'll start with the last one. Just towards the end of 2018, a new organization was launched called the Global Mental Health Peers Network. This grew out of the Movement for Global Mental Health, which is an advocacy group that all of you are welcome to join. It's for anyone who's got an interest in promoting mental health in the global context. But out of that group, people with lived experience of mental illness have formed a second group called the Global Mental Health Peers Network, which is meant to strengthen these kinds of conversations, Melissa, and meant to help galvanize people in countries where they may not have a big advocacy presence and there may not be the voice of people with lived experience, but how do we grow that? So there is an effort to do that. And I think what's nice is that the Movement for Global Mental Health has been a group of people that include users of services, researchers, clinicians, all kinds of people kind of coming together around this issue. So I think we need more of that, more opportunities for people to communicate. But that also means that, when we have convenings, when we have meetings, we need to have those voices on the stage along with everyone else that's reporting research, people reporting those experiences.
Peers can also be providers too. As part of our step care model, we have women who experienced abuse and mental illness but come out of that, be providers in step care model in Tajikistan in primary care. But then the challenge is, how do you appropriately support them? Because they're in a vulnerable position, and will the system bring them in either in a voluntary or in a paid capacity? There's long-term sustainability questions there, but they have a lot to contribute.
Okay, and in relation to the key levers to improve coordination, WHO encourages the formation of mental health steering committees or coordination committees in the countries. And these would involve the main stakeholders, whether it's Ministry of Health or NGOs or even the peer communities as well. And we find the countries that I have worked in, beginning with Uganda, of course, I find that we have a really big impact when we work together as one. So if I'm in the Ministry of Health, I'm not able to do advocacy. I can do what I did there, putting my hand up in the policy meetings, but somebody else has to be pushing from the outside, and that is the peer community. So in Uganda, we had a lot of organizations formed, Mental Health Uganda, parents of children with learning disabilities, the Epilepsy Support Organization, Schizophrenia Fellowship. So we've had a whole bunch of peers who do the advocacy from the outside and push the ministry. We have the NGOs, we have the academicians, and everybody working together. So every year, and most countries are now doing that, every year around World Mental Health Day, everybody comes together and has this big celebration of World Mental Health Day. And as a result of that, advocacy is done, awareness is raised, we fight stigma because people come out and talk openly about their mental disorders. And as a result of this, we begin to see a change in reducing stigma, but also in better impact when the programs are delivered. And as the others have spoken, peers are part of the programming. They begin all the way from policy. When you go into a country to do any kind of work, including research, it's always wise to have peers at the table with you. And the more we do this, the more we bring them out of the shadows. And that was our motto for 2014? 2016, out of the shadows. So, and there are peers everywhere who are able to actually participate in any kind of meeting, including this one. So we encourage the inclusion of peers in any situation. Thank you.
Well, I think it's time for us to wrap up. I think that these three presenters demonstrated to you all why they are my heroines in this field. I think they demonstrated that the revolution is indeed happening now, but we still have a lot of work to do. We hope that you'll join us. Thanks.